Tuesday, Don Berwick gave a talk for the first of what will be 4 ACO development workshops. And Don said that this is not for the inexperienced or the faint of heart. And he said the pioneer model is analogous to what he used in ski terminology, and I may get it wrong because I'm not a skier, but he said a black diamond slope, and it's only for the most expert to do pioneer model. And a lot of people, I think, when the pioneer came out, thought that this was a softening of the regs and might make it more attractive. He said the shared savings or the classic model is kind of the intermediate slope, and for the beginners, you need to start to prepare your organization, but you shouldn't dare go out on one of those slopes. And that's probably appropriate, and it may only be a handful of organizations that should do pioneer. And I think they are going to have a thorough vetting process. They're requiring a face-to-face team interview in Baltimore after you submit an application because CMS can't afford to have anybody fail. And I think that speaks to the payer-provider partnership that Steve alluded to, that we've got to break down the barriers. For those who, everybody's interested in ACOs, and there hasn't been a lot of publicity, but it's not embargoed anymore. But CMS and CMMI will be holding 3 more workshops that they're calling the Accelerated Developmental Series for ACOs. The dates aren't quite set. They'll be in September, October, and November in San Francisco, Atlanta, and Philadelphia. And if you follow on the CMMI website to track that, they're basically, they're 3 days, noon the first day through noon the third day, to allow people to fly in and fly out on that. And the requirement is you have to come with a team of senior executives from your organization to do some group learning, and there's a pre-work survey on your ACO readiness. Whether you're going to be an ACO or not, it really will help enhance your integration and planning for where you go. And from my vantage point, even if you're thinking about 2015 as an ACO, yesterday was not too soon to start down that road and get ready, because you can't just snap your fingers and flip the switch and make it happen. If there's more questions, write them down on index cards, and Julie and others will bring them up, but we'll start with some of the questions that I got. This is a question that we get from a lot of physicians who've been in the old paradigm, and we'll turn to Doug, but Greg, you can chime in too. As a physician, don't you think you lose that personal relationship with your patient when you practice with the team approach? And how have you convinced physicians to buy into that team approach?
Wow. I think that, actually, I think that you probably have more experience in the health home than Billings Clinic does. But I remember as a clinician working in the traditional model of that visit, and I found it I knew that the outcomes that I was getting with my patients were inadequate. I knew that the diabetics needed more than that 15-minute, or even double or triple the number of minutes that you have with that patient. You actually need the skill sets of others. And I like to practice at the top of my licensure and my skill set, and I think that giving that up is actually going to be the re-emergence, the rebirth of primary care, which has fallen in disrepute. And it actually is an opportunity for a whole new renaissance in primary care. You just have to put on a different perspective. What do you think, Greg?
Well, I think we've kind of used the model in our community where we look for innovators within our primary care practices, and we can usually find 1 or 2 that are willing to try something new, and we use them then, their success, to sort of share that knowledge with our other physicians, because we find that sort of peer-to-peer interaction between colleagues that you know, that you trust, if they say they're able to do this and it's working well in their practice, it's much more effective at getting spread. And so we really use that model a lot in our organization, is through those little QI projects that I talked about. Get a practice to do something, implement some change, present it to the group, get buy-in that way, and then the pieces just seem to start falling into place.
Greg, you said that clearly Billings didn't benefit financially from being in the PGP demonstration, and yet you said you're going ahead for the next 2 years and to continue. So what were the considerations and the reasoning for doing that?
You know, I think over the 5 years of the project, the 10 groups all across the country really started developing some relationships organizationally and personally. And we felt that we were critics of the Medicare system for so many years. This gave us an opportunity to try to change it. It wasn't optimally organized, and we have another chance to continue in that relationship. The more that we work with CMS, the more we realize that we learn from each other, and we can teach. In fact, I was talking we had a group session apart from CMS yesterday on the phone, that I caught up with, and they were commenting on the Minneapolis visit, or the presentation that CMS was doing, and they felt that they continued to perceive that CMS was learning just by that interaction with the groups that were at that meeting, which was about 200 folks there. And so that's why I would emphasize your encouragement to these groups, because you can actually influence how CMS perceives this is going to work, and perhaps change the regulations on the fly.
I would second that too. The shared learning, and Don Berwick on down would be the first to say they don't have all the answers, but they're confident that if we can collaborate, we can continue to improve the system, learn from our mistakes, and make corrections.
And something else that's kind of important is that our senior senator from Montana, Max Baucus, this was his baby, and so we work with him very closely, and when we finally encourage him to go through with something, which he stuck his neck out in the Senate Finance Committee, that's his bill, we need to follow through. So organizationally, that's what we've done.
Good. All of you can chime in on this, although it was directed towards Greg, but the question was, does your incentive reward system include the hospitals? And to go beyond that, we've all heard how the cost reductions have a disproportionate impact on the hospitals. How do they react to that? You're in an integrated system. Steve, you're on the outside looking in, and Greg, you're an IPA in a community with a hospital that you focus your business at.
We, historically, we have not really engaged the hospitals in our community in our incentive programs and that kind of activity. Somebody showed a slide yesterday that the greatest cost driver in healthcare is a pen, the doctor's pen. And so we're focused on the physicians really in our community, and trying to get them organized around quality and good, efficient care. Now, we understand, though, that going forward, we really need to engage more with the hospital, and we're now reaching out to the hospital and trying to just sort of test the waters on a few pilot projects where we're going to work with the hospitals on a readmission decrease program within our IPA in the hospital. And so we're going to sort of test that relationship and see how things work going forward, and potentially we could have a stronger relationship in the future where we were actually more financially integrated with the hospital system. But up to this point, we've basically just done it within our physician organization.
I think ultimately you have to engage the hospital, but what we notice is a difference between the situation Greg's in Billings, where there's a single hospital in the community, or there's a hospital closely aligned that you use almost exclusively with your physicians, and that over time that'll be much easier to do, to get that kind of engagement and integration, than it is where you are in a community where your doctors use 3, 4, 5, or 6 hospitals. And how to engage that situation, because each of those hospitals will also has other doctor groups and so forth and so on, and how these ACO boundaries might be drawn is a much bigger challenge. So I think you really need to separate it out that way and kind of approach it.
In the PGP, there were 2 physician-only groups, Marshfield and Everett, and they had difficulty getting information from their hospitals. And they didn't want to talk about it. They only saw it as a revenue loss. But at this point in time, I think they realized that they need to start engaging with those groups, and there's indications that they are. Because I think that a hospital that doesn't engage with an IPA like yours, Greg, or with those groups, really does so at their own peril. And they're going to make the wrong decisions about budgeting and strategic planning and everything else.
So what were some of the challenges and decisions Billings had to make regarding budgeting and allocation of revenue or costs between the hospital side and the physician practice side?
Well, in 2004, 2005, when we were starting this program, we actually were at 100% capacity many of the days. And we are now running at about 80% capacity on a regular basis. So now the recession, I think, had an impact. There's no doubt about it. But we had physicians who were clamoring for us to build another patient tower, and we held off. And we haven't added a single bed in 15 years.
Wow. Yeah, that's a story that's going to play out in most markets across the country. What percentage of Billings Clinic revenue came from Medicare?
50%.
5-0.
Yeah.
All right, so that's higher than most organizations. What do you think is the tipping point to create the alignment, whether you call it ACO or shared savings? Because most organizations could probably be between 20 and 40% of revenue coming from Medicare.
The tipping point from Medicare or from any?
No, that would get you to redesign and buy in and start to treat everybody in the new paradigm because, as Steve nicely showed, you've got all the conflicting incentives and the resistance.
Yes. That's difficult. It would have a bigger impact on the commercial side because, the commercial is only about 40% or 35%, and yet that's where all of our margin is right now. So if those payers were coming forward with it, we would have to we have to be more careful about that side than we do on the Medicare or Medicaid side.
Steve?
Yeah, I think, again, the few we've talked to about this, it ranges from about 1/3 to 50%. Now, that's a very small sample, 4 or 5 hospitals or health systems, namely that when the percentage of my revenue is under something other than the DRG rate or whatever I have, that I'm going to begin to switch, and I'm going to be really engaged. They're doing some pilot things, little things now, but we'll begin to expand it. So that was basically the response from one. And then another, I've got to wait till it's about half, the 50%. But they were talking the private as well as Medicare, but they were mostly talking about the private. So it'll be interesting to see in some of these early demos, Tucson, the Sutter, Sacramento hospitals, how these beginning contracts are going to shift the behavior in those hospitals and within those systems. So I think this is what I mean by a learning system, is let's track that early on. Let's not wait for a couple of years and then Sutter shows some numbers and it failed. Let's learn as we go along. So it's very interesting.
Because most of the early demos are very small portions of the business, and short of just a small group of physicians and leadership that's committed to do it, it's going to be a lot of resistance. I can say firsthand, our commercial shared savings contract is 29% of our system's revenue. We are far from the tipping point. Okay. We constantly hear about how it's disadvantaging top-line revenue and profitability on the rest of the business. And, you know, as Doug pointed out, it's only the commercial business that has real margin. So it is the majority of our commercial business, and yet, you know, we're going through the change process. One of the questions that came in is there a reasonable financial reason, and maybe we can expand to other reasons, for an average size PHO to get into accountable care organizations now versus waiting 5 years and letting things play out?
Greg, have you been looking at that?
Well, I think that, I guess we've looked at it in sort of really two different ways, and maybe that's what we need to define. If we're talking about a CMS certified ACO versus an ACO for the commercial market, I mean, our focus is at this point going to, you know, get our hands better around the commercial market, and again, we like the idea of fewer measures, focusing on things that really are important, and working directly with the payer to collaborate and decide what those measures are going to be, rather than have the payer tell us what they want us to measure. And so for our organization, our size, our Medicare fee-for-service population, at this point, we're not really pursuing a CMS certified ACO for that reason.
We all agree there's a long learning curve, and don't you think that you need to look on, even if they're short-term as negative financial consequences, it's an investment in the future, in whether the market lands on CMS-type ACOs or something else. It forces you to redesign your system and improve care, and at the end of the day, that's where we need to go. We've heard lots of examples and mostly focused on Medicare. One of the things that strikes me that I haven't heard very much of in the last 2 days is more relevant in a commercial population, but probably the biggest opportunity to reduce expenses is in obstetrics. And, you know, reducing premature births. The Leapfrog group is now on a national campaign to eliminate elective inductions before 39 weeks. There's very good evidence to support that. You know, I've heard Brent James share his data 5+ years ago, and yet in our community, there can be 20 to 25% elective inductions before 39 weeks. When I trained, people thought as long as it was more than 36 weeks, the lungs were mature, the baby's going to be fine, and data kind of refutes that. So be interested in, you know, what your organizations are doing, if any, in the obstetrical area and other opportunities in obstetrics and women's health to redesign and take costs out.
Well, we certainly have adopted that same approach in terms of, you know, talking about no inductions until 39 weeks. But what you find in organizations is when I first started asking that question in my organization, I was told, oh, well, we haven't done that for years. But then when you actually look at the data, it's sort of like the disconnect with the primary care physician saying, oh, I do this for all my patients. And then you find out it's actually 35% of your patients actually get that care. But, you know, so that is, the data has to drive the discussion. And in fact, I think that's important. You can't assume that if you have a policy that it's going to be followed.
We, probably over a decade ago, the providers in our community realized that the absence of early prenatal care was certainly a risk for premature birth. So we got together, and one of the providers in our community, Hilltop Community Resources, put together a program called B for Babies. And what that is that's a process where pregnant women can access the B for Babies program quickly. They get linked up with one of our healthcare providers quickly. They sort through all the eligibility issues, if they're eligible for Medicaid or not, get that done quickly. And so it's really been a great program in our community to get women early prenatal care.
Okay. I'm going to ask all three of you to comment from your perspectives. What's the skill set and how can we train the right people to be leaders in the new paradigm, whether you call it ACO or managing under a global budget, but to, you know, bend that cost curve and make healthcare affordable and sustainable.
Maybe I'll start out. I think this actually came up at the conference the other day. I think some of the things that are absolutely going to be critical, we need a lot of analytic skills, and I don't mean necessarily that we need to train physicians and nurses to be experts in clinical informatics, if I can use that term, but we need the clinical informatics people and the IT people, but the leaders need to understand that language, understand some of the basic processes involved, and need to engage that. We are moving to this data performance measurement world, and we need to read more than just numbers. We need to understand what's behind the numbers, what they mean, the interrelationship of the numbers, what can change fast, what can't, what's controlled for, what's not controlled for. So that is going to be an increasing skill. Another set of skills is going to be around managing change, managing conflict, managing situations, situational leadership approaches. Most of us have a comfortable preferred style of interacting with people, and often it gets reinforced. That's the way we've been successful. We get promoted, but it doesn't work when you do it across the board. So you have to kind of know where people are coming from. I've learned, for example, that if I'm presenting to a group of surgeons, right, and I start out talking about a bunch of stories and pictures, you'll lose them. Where's the data? Fast, you know, I'm in there cutting and I need the data, and so show me a bunch of tables or data, the facts and the evidence. It's a group of pediatricians, and I start doing that, their eyes glaze over. Where's the person? Where's the baby? Where's the mother? Tell me a story. You know, people just, I'm generalizing, of course, but nonetheless, so we need people who are sophisticated about managing change, managing negotiation skills. Negotiation skills, very, very important. So these are some of the, we could elaborate, but these are some of the skill sets that are going to be needed.
Yeah, I think that's a huge challenge, I think, for our organization. And historically, we've just had people step up into leadership positions, and that's been a reasonably effective model for us. But you know, that's not the way that we're going to be able to go forward. We're finding that as we approach young physicians about leadership roles, participation on committees and things, the response is usually negative. They're less interested in doing that kind of work. And so we really have to keep our eyes and ears open on anyone that we hear about, a young physician who maybe is working in their practice on QI or some leadership role in their practice, approaching them about leadership opportunities within our organization. Ultimately, we know we need to provide training programs for those people. We've talked about budgeting for sending young leaders to training programs by the American College of Physicians or some of the other organizations that really help with the kind of skill sets that you were talking about. And so, you know, that's a big problem. I think in most organizations, the leaders tend to be older, maybe people who are approaching retirement or who are past the height of their career. You accepted, of course. And I think we just need to get more young people involved, young physicians involved in that activity in some way.
You know, clearly physician leadership is lacking. You know, physicians all are informal leaders in their area of where they work and in their teams, et cetera. And clinically, they lead. But quite frankly, the kind of training that they get in medical school that I got and they're currently getting really are sorely lacking in terms of trying to hone the skills of leadership. And I think a good example, and I would say, would be that table over there with the Baylor folks. And they actually embarked on physician leadership development at the start of last decade. And the group, the physicians that are at that table are part of the governance of their new ACO, and all of them have gone through their leadership courses that they had on site. They modeled them after the American College of Physician Executives, and they ended up putting their own style, but I think I was told that almost like 1,400 of their physicians have gone through some form of physician leadership. And then obviously the ones around the table there have often gone on to get their masters in management, as many of us have. So, you know, these are investments that I think that was financed by mostly the hospital and the hospital system. And I think that hospitals that don't make that investment and look at the long term are going to find that they have a leadership gap. And Dr. Shortell emphasized that as the single most important aspect.
Well said. The irony, while we were here this morning, I got an email from Dr. Larry Castellino, who's spoken at this conference several times and Steve collaborates with, and Larry's question is, where can we send physicians from Weill Cornell Medical School, one of the most preeminent medical schools, to learn more about global cost management and accountable care organizations? So both making the commitment and then where do you get them exposed so that they can learn the skills that they need? Okay. And there's a whole group here from Ithaca, so how ironic that the medical school will go upstate.
In the spring and summer.
Yeah.
With that. Greg, who owns the Rocky Mountain Health Plan? Not a brand that is familiar to the rest of us.
It's a not-for-profit health plan that's basically owned. There's some founding shareholders for that, but it's locally owned.
Yeah, that clearly is a unique attribute and led to some of the collaboration. How was your health information exchange funded, and how was it initially capitalized?
Well, kind of an interesting story. Rocky Mountain Health Plans back in the early mid-1990s actually filed a lawsuit against the state of Colorado and the Department of Health or HCPF for what they felt was underpayments regarding the Medicaid population that they were managing. And over the course of 3 or 4 years, that lawsuit actually ended, and Rocky Mountain Health Plans was successful in recapturing some dollars from the state for underpayments to healthcare providers. Now, what we did is we decided as a community that was sort of new money to us, and there was a lot of debate about, well, if the money was really underpaid or meant to be paid to providers, shouldn't you just give it back to all the providers who were underpaid? But as a community, we got together and said, no, let's put this money to a different use. And so that's where we capitalized and got the initial dollars for the health information exchange. Now the way it's funded is through a subscription model where various organizations pay a subscription fee per physician or per user for their system that's using it. Some physicians just write the check themselves if they're not in the IPA. Some hospitals pay for it for their physicians. But it is a subscription model, a per month fee to be part of that.
A lot of foresight to not grab the money and use it for short term, but to invest it. And I think it's fair to say that most physician groups operate on a cash basis and don't build up any equity or make long-term planning, and it's something that will need to change. Somebody wants to know if your IPA has ever been sued by any physicians that were kicked out.
Looking at our attorney, I don't believe so. I haven't been there for the whole.
Not yet.
I haven't been there for the 35 years, but I'm not aware of any physician suing the IPA for getting kicked out. We haven't kicked out a lot of physicians. The physicians that don't like us leave voluntarily for the most part, and so that's happened. And our certain specialties we get crossways with once in a while, and it sort of ebbs and flows. They're in, they're out, and we're fairly inclusive now. In general, if physicians want to be on our organization, they can be in our organization. But knowing that there's going to be some data, there's going to be some data sharing, and they need to be prepared for that kind of activity.
You know, I can say in Advocate Physician Partners, we've never been sued when we haven't recredentialed a physician, and you know, it's not something that we aim to do, but there are physicians who choose not to perform, and when they don't meet minimal standards, and after getting notice, they're gone. And we've had some threats, but usually when they sit down and review the circumstance, they realize that they can't defend their actions and that we would win with that. And it's important. I mean, it goes to channeling business to cost-effective physicians who drive the best outcomes. And you know, as long as people are moving in that direction, that's great. But for the handful that choose not to, you can't afford to keep them in the organization with that. You know, let's wrap things up. The same question I asked the panel at the end yesterday. I tend to see the glass half full, but I'm interested in the three of your perspectives, whether it's half full or half empty. What do you see as the biggest challenges, and what gives you confidence that our industry is going to bend that cost curve and really create sustainable health care for the next generation? We'll start here and let Steve get the last word.
I think that's a good idea. I'm optimistic. I mean, I don't think I could get up in the morning and go to work if I wasn't. And I know it's going to happen, but unfortunately, I think the real question is, are we going to wait till crisis before we make these changes, or whether we're going to be ahead of the crisis mode? That obviously is how Washington works, and I'm hoping that healthcare works a little bit differently. I think that there is going to be a lot of disruption. Dr. Shortell talked about the fact that it also includes money, and it's not just a matter of squeezing waste out of the system. People are getting paid by that GDP expenditure, and there are going to be some winners and losers. And when I was thinking about your context of delisting, certifying a low-value person, I'm sure that basically you'd love to have them work for your competition. And that's really what it's going to have to get to the point, is that there are going to be people who understand how this new paradigm works, and they're going to be successful. And I think that there will be happiness in those camps. But the people that don't embrace it, don't try to figure it out, are going to be the clinicians who are still struggling with paper charts and are left by the wayside. It's going to be akin to that. And it's also going to include, you know, I think that it's safe to say that of the, how many insurers are there in this country? About 5,000? Probably about 5,000. I don't think there are going to be 5,000 insurance companies in this country. I don't think there's going to be, you know, that host of paper pushers in all of our organizations and in the intermediaries. I think that everything is going to get leaner, and we're going to have to find them jobs doing other things. So it's going to be a big change, and it's going to occur quicker than we think. I don't think it's going to be 10 years out. It might be somewhere between 5 and 7, but it's going to happen fast when it does happen.
Okay. Greg.
Well, I'm optimistic also. I think that, you know, fortunately for me, I'm in a community that's already in the in tune with what collaboration is all about and cooperation. But I can tell you, I have the same type of concerns that our other panelists have about the money. And, you know, I have an expression that somebody's waste is somebody's revenue. And unfortunately, I think we just going to, over time, need to change expectations amongst healthcare providers of what kind of incomes they're going to make, how those incomes are going to be earned, and that's going to be, I think, the steepest hill to climb for our organization and for many others, is just getting people more in tune with working together. I think there's going to gradually be probably a shrinkage of the discrepancy between the highest earning physicians and the lowest earning physicians. There'll be some shrinkage of that, which is naturally going to occur. And hopefully we can keep those physicians at that other end still engaged and willing to participate and not just throw up their hands and say, I'm finished, if this is the way it's going to go. But I think that that's the biggest hurdle, but I'm optimistic that with collaboration, some peer involvement, that can happen.
Yeah, I think it's clearly a journey, and I would be more optimistic if there were more people out there, like people on the stage here and those of you in this room. I believe in self-fulfilling prophecies. So I believe that you can create momentum within your organizations in which, despite all the day-to-day challenges of significant changes that need to occur, you have the will and the persistence, right, to go on, to make those things happen and to take some control of your future. So I think in terms of the journey, my hope would be that in 3 or 4 years, with all the experimentation that you're beginning to engage in, I do not think the pessimistic side, or maybe the realistic side, I really do not believe enough's going to occur fast enough to show bending of the cost curve. And I worry, and a lot's going to depend on the politics and where our country's at the time and who's president and so forth. But as I said earlier, one scenario is the crisis, the draconian cuts that will be implemented. And then you will be in that brave new world. But I hope, even if that were to occur, that where we will be in 3 or 4 years is in a somewhat reorganized delivery system in the United States that will make enough progress that there'll be a new platform out there in most of our communities to, in the following 3, 4, 5 years, bend the cost curve. I don't think we're going to do it in the next 3 or 4. Then will we have the patience and the intermediate outcome indicators? Look what's happening in Chicago. Look what advocates doing. Look what's happening in Montana. Look what's happening in Colorado. Look what's happening in California, wherever you're all from, that show in those intermediate indicators significant progress and a platform in which the new doctors and nurses and others coming out are practicing in much more cost-effective delivery systems, right, that are serving our communities. That is what I'm hopeful for, and I think actually can be achieved. But it won't show up for another 4 or 5 years after that.
Well, we all need to start moving in that direction so that it does happen. And if you think about the worst case scenario, whether it's 3 years or 5 years, draconian reimbursement cuts, shame on us if we can't avoid that, because it won't be fun and it won't serve our patients. A couple of thank yous as we wrap up. Again, I want to thank the VHA for supporting ICQV with their meetings staff, Rosemary, Kelly, and Becky, who've been here and have done this for the last 3 years, just do an outstanding job. Thanks to Group Practice Forum for providing the video services and will enable us to post the presentations on the website so that you can share some of the learnings with colleagues back home and help facilitate some of the change. And a particular thanks to the 3 people up here with me this morning. Outstanding presentations. Really appreciate you being willing to come and share your insights with that. And safe travels for everybody. Box lunches are outside.